Welcome back to the Deep Dive. Today, we are opening up a resource that, well, it usually sits on the reinforced shelves of surgical libraries, not necessarily on the bedside table. We're tackling Chapter 65 of the 28th edition of Baily and Love's Short Practice of Surgery.
And it's a chapter that carries a pretty heavy title: the peritoneum, mesentery, greater omentum, and retroperitoneal space.
Right.
And I think for a lot of medical students or, junior trainees, this is the section they flip past to get to the exciting stuff.
Like trauma or transplants, yeah.
Exactly. But that is a huge mistake.
A massive mistake, because what we're discussing today isn't just a list of anatomical borders. It's the roadmap. Our mission for this deep dive is to interpret this chapter, not recite it, but to translate it.
To make it stick.
Yeah, to turn it into a ready reckoner. We want this to be the revision tool you use before your exams or, honestly, before you scrub in for a laparotomy.
That's the key. We are not replacing the text. You absolutely still need to read Chapter 65. But we're going to provide the framework, the hooks to hang all that detailed information on.
And we have to start with what is really the headline news from this edition.
The paradigm shift.
Right. The text makes a very big deal about moving away from the old peritoneal model and fully embracing this new mesenteric model. It's framed almost like a grand unified theory of the abdomen. Why is this shift so fundamental?
Well, for roughly 100 years, we taught anatomy as if the mesentery, the tissue that holds the gut up, was fragmented.
Like different pieces for different parts.
Exactly.
Okay.
We taught that there was a mesentery for the small bowel, a separate one for the transverse colon, and so on. But the mesenteric model argues that the mesentery is actually one continuous, singular organ.
One continuous organ. So instead of a patchwork quilt, it's a single sheet.
It is a single sheet. And that changes everything. It changes how we understand the spread of disease, specifically things like Crohn's or cancer, and it fundamentally changes how a surgeon navigates the abdomen.
How so?
If you understand the continuity, you understand the blood supply. If you understand the blood supply, you don't accidentally kill a section of bowel.
Which is generally considered a good day in the operating theater.
A very good day.
So to really get this, we have to go back to the beginning. We need to look at the origami of life. Let's start part 1, development.
To understand the adult abdomen, which, let's face it, looks like a chaotic bowl of spaghetti,
Right.
You have to look at the embryo. In the beginning, the abdomen is incredibly simple. Just imagine a room, the colon. It has walls.
Simple enough. A room with 4 walls.
Now, divide that room in half with a vertical curtain. That curtain is the primitive mesentery. It splits the cavity into a right space and a left space.
And the text describes this curtain as a sandwich.
It does, and it's a great analogy.
Okay, so let's break down the sandwich layers, because this histology really matters later on.
Okay, so the filling of the sandwich is the mesoderm. That's the connective tissue, the blood vessels, the nerves. That's all the infrastructure.
Important stuff.
And the bread on either side is a layer of mesothelial cells. That is what becomes the shiny peritoneum we see in surgery.
So we have a vertical divider, but humans aren't, simple vertical tubes with coils and twists. How does this sandwich become the complex anatomy we see in an adult?
This is where the folding comes in. Baily and Love divides the primitive mesentery into 3 regions: upper, mid, and lower.
Okay.
The upper is the pre-fold region, the lower is the post-fold. But the mid region, that's where all the drama happens.
And this is the area supplied by the superior mesenteric artery, the SMA.
Correct. Now, for you listening, visualize this. The midgut grows incredibly fast, way faster than the abdominal cavity can hold it.
So it runs out of space.
It completely runs out of space. So, around week 6 of life, it actually bursts out of the abdomen and goes into the umbilical cord. This is what's called physiological herniation.
It effectively leaves the building because the room is too small.
Exactly. But it doesn't just pop out and sit there. It starts to rotate. It rotates 90 degrees counterclockwise around the axis of the SMA.
Okay, wait. So at this point, the appendix and the cecum are on the left side, and the small bowel is on the right. It's all horizontal.
It is, but it can't stay outside. By week 10, the abdomen has grown enough to welcome the gut back home. And as it returns, it rotates another 180 degrees counterclockwise.
So that's a total of 270 degrees of rotation, a 3/4 turn.
Yes. And this final rotation is what we call the switch. This is the critical concept the text really emphasizes. The mesentery of what was the right side and what was the left side effectively swap places.
Let's slow this down, because this is, I think, the hardest part to visualize without a diagram in front of you. The switch.
Okay. Think of it like a dance around a pole. The pole is the superior mesenteric artery. The loop that will become the colon swings over the artery to land on the right. The loop that becomes the duodenum swings under the artery to land on the left.
So the duodenum gets tucked behind the SMA, and the colon is draped in front of it.
Precisely. That relationship duodenum back, colon front is the switch. If that dance move is missed or if they trip over each other, you get malrotation. But if it works, you now have the gut in the right place. However,
Still floppy.
it's still floppy. It's hanging loose in the middle.
And a floppy gut is a dangerous gut because it can twist on itself, so we need to glue it down.
This is the process of adhesion. The mesentery flattens against the back wall of the abdomen, the posterior abdominal wall, and literally fuses to it. And the text describes a specific directionality to this glue. It happens from the midline outward.
Like smoothing out a poster on a wall. You start in the middle and you push to the edges to get the air bubbles out.
That's a perfect analogy. So in the upper region, the adhesion moves to the left. This anchors the pancreas and the spleen. That's why your spleen sits high and fixed in that left corner.
And the mid-region.
It adheres to the right. This is what anchors the ascending colon.
So left, then right.
Right.
What about the lower region?
It goes back to the left, anchoring the descending and sigmoid colon. So the pattern is left, right, left.
And this fusion, this gluing process, it creates a new layer, doesn't it? When the mesentery glues to the wall, it doesn't just vanish.
No, and this is absolutely crucial for the surgeons listening. When that mesentery fuses with the wall, it creates a plane. The text calls this Tolt's fascia. It's a distinct connective tissue layer.
Why is Tolt's fascia so important? I mean, it sounds like just another layer of tissue.
It is the holy plane of abdominal surgery. Because this fusion plane is relatively avascular, it doesn't have major blood vessels running across it. The vessels run within the mesentery layers themselves.
Oh, okay.
So if a surgeon can find Tolt's fascia, they can peel the colon off the abdominal wall, mobilize it, without causing any significant bleeding.
It's like peeling a sticker off a backing sheet.
Exactly.
If you find the right layer, it comes off clean.
It comes off clean. If you dig too deep into the backing sheet, that's the retroperitoneum, you hit the ureters and the big blood vessels. If you go too shallow, you damage the bowel's own blood supply.
So Tolt's fascia is the safety zone. Okay, I want to do a quick check-in here. For you listening, pause for a second. Can you visualize the switch? Can you see the colon swinging in front of the SMA and the duodenum tucking behind? And importantly, remember that left-right-left pattern of adhesion. If you can't picture that, honestly, rewind. The complications we're about to discuss, like volvulus, they won't make sense unless you understand how things are supposed to be stuck down.
That's a great point. And that leads us perfectly to part 2. The text introduces a conceptual framework it calls the two kingdoms.
The mesenteric domain versus the non-mesenteric domain. This ties directly into what we just said about the embryology.
It does. The mesenteric domain consists of the organs that developed on that floating partition. You know, the stomach, small intestine, liver, pancreas, spleen. These organs are the floating island. They brought their own blood supply with them.
And the non-mesenteric domain.
That is the seafloor. These are the organs that developed on the abdominal wall itself. The kidneys, the ureters, the gonads. They are built into the bedrock of the body.
And the bridge between the island and the sea floor is that point of adhesion, that Tolt's fascia we just discussed.
Exactly. Baily and Love calls this the peritoneal reflection. It's where the visceral peritoneum, the skin of the island, turns into the parietal peritoneum, the skin of the wall.
And the text really emphasizes that understanding these two domains is the key to vascular safety in surgery.
It is the absolute rule. The coeliac axis, the superior mesenteric artery, the SMA, and the inferior mesenteric artery, the IMA, along with the portal venous system, are strictly intramesenteric. They live on the island.
Conversely, the aorta and the vena cava live on the seafloor.
Right. So conceptually, if you are removing a section of colon, which is in the mesenteric domain, you should never be seeing the aorta, a non-mesenteric structure, unless you have intentionally crossed that bridge.
So it's a warning system.
It's a huge warning system. If you're dissecting the colon and you suddenly see the vena cava and you didn't plan to, you have gone off-road. You have crossed the line of Tolt, and you have entered the retroperitoneum.
You're now leaving the mesenteric domain.
Precisely. And this leads us naturally into part 3. The peritoneum itself, it's not just a passive shrink wrap, you know. It's a physiologically active organ.
the surface area is massive, something like 2 square meters, which is roughly the same as the skin. But let's talk about the fluid dynamics, because this explains where infection goes in the abdomen.
Absolutely. The peritoneum secretes fluid for lubrication, but it also absorbs it. And the absorption isn't uniform. It's driven by what the text calls the diaphragmatic pump.
This is fascinating. I think most people assume gravity rules everything in the abdomen. You stand up, fluid goes down to the pelvis.
Well, gravity plays a part, certainly. But there's a hydrostatic pressure gradient at play. When you exhale, the pressure in the abdomen drops slightly relative to the thorax. This creates a kind of vacuum effect. A suction, exactly. The peritoneum under the diaphragm has these specialized pores stomata that actively suck fluid and particles upward.
So even if a patient is lying flat or even sitting up, there's a constant upward pull of fluid toward that subphrenic space.
Yes. The lymphatics under the diaphragm are the main trash collectors of the entire abdominal cavity. They suck up bacteria, debris, everything.
Which explains that old surgical axiom, puss somewhere, puss nowhere, puss under the diaphragm.
Exactly. We'll get to abscesses in a moment, but that mechanism is precisely why the subphrenic space is such a hot spot for infection.
Before we get to the pathology, we need to clarify pain. This is probably the most high-yield concept for a medical student on call, the difference between visceral and parietal pain.
It's all about the nerves. It's the difference between the island nerves and the wall nerves. The visceral peritoneum, the island, is innervated by the autonomic nervous system. It's blind to touch or temperature. You can cut the bowel and the patient won't feel a sharp pain.
But it does feel stretch.
Oh, it hates stretch and distension. But the brain can't localize it. It just screams, help, something is wrong in the middle, and it maps to the embryonic midline. So foregut problems hurt in the epigastrium, midgut problems in the umbilical area, hindgut in the suprapubic area.
Now contrast that with the parietal peritoneum.
The parietal peritoneum, the wall, is innervated by somatic nerves, the same nerves that supply your skin and your muscles. It is incredibly precise. If inflammation touches the wall, the brain knows exactly where it is. It's like a GPS coordinate.
Let's run a quick case study 1 to lock this in. A 20-year-old male starts the day with a loss of appetite and this dull, vague ache right around his belly button. He ignores it. 6 hours later, he's walking hunched over, holding his right side, and he can point with one finger to a spot that hurts sharply when he coughs.
That is the classic textbook timeline of appendicitis.
So walk us through the physiology of that pain migration.
Okay, phase 1. The appendix is blocked and it's starting to distend. This is visceral pain. The appendix is a midgut structure, so the pain is referred to the umbilical region. It's vague and cramping.
And then phase 2, the inflammation spreads.
The appendix gets so inflamed that the outside of it becomes sticky and angry. It starts to rub against the abdominal wall and the right iliac fossa. Now, the parietal peritoneum is irritated, the somatic nerves fire, and the brain suddenly gets that GPS coordinate, danger in the right lower quadrant.
And that migration of pain from central to specific is the diagnostic key. If you understand the anatomy, the history just tells you the diagnosis.
Absolutely. Now let's look at what happens when that inflammation isn't contained. Part 4, peritonitis.
This is inflammation of the lining. This is what creates the acute abdomen. We have the classic signs: tenderness, guarding, rigidity.
Right, and let's distinguish those. Tenderness is pain when you press. Guarding is when the muscles tense up as you press. It's a voluntary or a semi-voluntary defense. But rigidity, that is the board-like abdomen.
Why does the belly turn into a plank of wood? What's the mechanism there?
It's a spinal reflex arc. The parietal peritoneum is so intensely irritated that the nerves trigger a sustained spasm of the abdominal muscles to prevent any movement whatsoever. It's an involuntary splint.
You can't talk them out of it.
You cannot relax a rigid abdomen, even if you try.
Okay, we need to cover some specific types of peritonitis because Baily and Love lists a few that are very distinct from the standard burst appendix. Let's talk about spontaneous bacterial peritonitis, SBP.
Spontaneous is the key word. It means there is no hole in the gut. This typically happens in patients with liver cirrhosis who have ascites fluid in the abdomen. The bacteria just stop. They translocate across the bowel wall into that fluid.
And the diagnosis here relies on numbers, not just a gut feeling.
Correct. You have to tap the fluid, you put a needle in, and draw some off. If the neutrophil count is greater than 250 cells per cubic millimeter, that is SBP, and you treat with antibiotics immediately, you do not operate.
Right, because there's nothing to find, nothing to sew up. Now, biliary peritonitis.
This is nasty stuff. Bile is incredibly irritating chemically. This often happens after a laparoscopic cholecystectomy if a clip slips off the cystic duct. The patient is in agony, and they often go into shock because the chemical burn draws massive amounts of fluid out of the bloodstream and into the peritoneum.
A huge fluid shift. And then TB peritonitis. The text says this is seeing a resurgence.
It is. Tuberculosis is a great mimic. It comes in 3 forms. The wet form, which presents with ascites, the fibrotic form, which causes obstructions, and the dry or plastic form.
And the text describes the abdomen in that dry form as having a doughy feel.
Yes, doughy is the key word. It feels thick and unresponsive because all the intestines are matted together with these sticky, fibrinous adhesions. Diagnosing this is really hard because culturing TB takes weeks.
So is there a shortcut test?
ADA, adenosine deaminase levels in the ascitic fluid. If the ADA is raised, it's highly suggestive of TB. It allows you to start treatment while you're waiting for that culture to come back.
One more specific type, familial Mediterranean fever, FMF.
This is a genetic disorder, specifically a mutation in the MEFV gene. It causes these recurrent, horrible attacks of peritonitis pain, fever that lasts 1 to 3 days. And the tragedy is that many of these patients undergo unnecessary surgeries because it looks exactly like appendicitis or a perforated ulcer.
And the treatment is completely medical.
It is. It's colchicine.
Yeah.
And it's vital not just for the pain, but because untreated FMF leads to amyloidosis, which eventually destroys the kidneys.
Okay, let's move to part 5, fluid collections. We've touched on ascites, but we need to break down the difference between a transudate and an exudate. Baily and Love gives us a hard cutoff number.
The protein content, 25 grams per liter.
So if it's below 25.
It's a transudate. Think thin and watery. This is caused by pressure imbalances, Starling's forces. So heart failure, liver cirrhosis causing portal hypertension. The membrane isn't broken. The fluid is just being pushed through by pressure.
And above 25.
It's an exudate. Think thick and protein-rich. The membrane is inflamed or leaky. This is infection like TB, malignancy, or inflammation like pancreatitis.
And there's also a rare one mentioned, chylous ascites.
Right. This looks like milk. It's full of triglycerides. It happens because the lymphatic channels are blocked or damaged, often by lymphoma, or sometimes after major trauma.
Now, abscesses. We established the puss under the diaphragm rule because of the pump.
We did. But let's talk about the clinical presentation. A subphrenic abscess is often insidious. The patient has had surgery maybe a week ago. They seem to be recovering, but then they start spiking fevers, a swinging pyrexia. They don't look right.
And the signs can be subtle.
Very subtle. They might have a bit of a cough or some shoulder tip pain.
The shoulder tip, that's the diaphragm referral again, right? The C5 dermatome.
Yes, exactly. Right. The diaphragm is irritated, so the C3, C4, C5 nerve roots refer pain up to the dermatome on the shoulder.
What about pelvic abscesses? Gravity pulls pus down there when we're standing up.
These are tricky because the anterior abdominal wall is often soft. You can't easily feel a mass. Instead, the abscess irritates its adjacent organs.
The neighbors.
Exactly. It irritates the rectum, causing diarrhea or mucus in the stool. It irritates the bladder, causing urinary frequency. So if a post-op patient suddenly has mucus in their stool and needs to pee every hour, you have to do a rectal exam. You might feel that boggy, tender mass of an abscess.
Okay, let's move into part 6. Mesenteric pathologies. This is where the beautiful anatomy we built in part 1 starts to fail. Let's start with ischemia.
The gut is a high-demand organ. It needs a lot of blood. Acute ischemia is, for all intents and purposes, a heart attack of the gut. Usually an embolus, a clot from the heart, flies off and blocks the SMA.
And the presentation is dramatic.
It's pain out of proportion to physical signs. The patient is screaming, writhing in agony, but when you press on their belly, it's soft. The gut is dying, but the parietal peritoneum hasn't been irritated yet.
That is a deadly trap for the inexperienced. But there's also chronic ischemia, abdominal angina.
This is a slower process. It's atherosclerosis narrowing the arteries. The gut gets just enough blood to survive at rest, but as soon as you eat, the demand for blood goes up. The supply can't meet it.
So the patient gets terrible pain every single time they eat.
Which leads to the hallmark symptom, a fear of eating. They're hungry, but they're terrified of the pain that will follow, so they lose massive amounts of weight. It's often mistaken for cancer.
Now let's go back to our dancers from part 1, malrotation, when the switch didn't happen correctly.
Right. So if the gut doesn't rotate and then fix itself in the corners, the entire midgut hangs on a very narrow stalk of mesentery, a narrow base.
And physics dictates that a narrow base is incredibly unstable.
Exactly. It's prone to twisting. This is midgut volvulus. It cuts off the entire SMA, The whole small bowel dies if you don't act fast.
And the fix is Ladd's procedure. This isn't just untwisting it, is it?
No, you can't just untwist it and leave it. It'll just twist again. In Ladd's procedure, you first unclip the bowel, which is counterclockwise. Then you divide any fibrous bands, they're called Ladd's bands, that are crossing the duodenum. And then you try to widen the mesentery base as much as possible to stop it from twisting again.
And you remove the appendix.
Always. You always take out the appendix because you are placing the cecum on the left side of the abdomen. If that patient gets appendicitis in 20 years, no one will ever diagnose it because the pain will be on the wrong side. So you take it out to prevent any future confusion.
That's a great clinical pearl. Okay, now volvulus in adults. The book distinguishes sigmoid versus cacal.
Sigmoid volvulus is much more common. It's a disease of the elderly, often with chronic constipation, maybe some neuropsychiatric disorders. The sigmoid colon gets long and floppy, and it twists on its mesentery.
So let's run case study 2. An elderly nursing home resident comes in with a massively distended abdomen. It sounds like a drum when you tap it, tympani. But they haven't started vomiting yet.
Right, no vomiting yet because the block is huge and it's low down. The x-ray shows the classic coffee bean sign, a massive loop of gas that seems to rise out of the pelvis.
And cacal volvulus.
This is different. It tends to be younger patients. And it's often a congenital failure of that bottom right adhesion we talked about earlier. The cecum just isn't glued down properly, so it flips up. The x-ray looks more like a kidney bean, not a coffee bean, and it points to the left upper quadrant.
Let's touch on mesenteric adenitis.
The great mimic of appendicitis in children. It's just inflammation of the lymph nodes in the mesentery, and it usually follows a viral throat infection.
So a strep throat of the tummy.
Essentially, yes. The key is that the pain often shifts around or isn't as precisely localized as appendicitis, and they'll nearly always have a recent history of a cold or a sore throat.
Now, Crohn's disease. The text describes a very specific appearance of the mesentery.
Fat wrapping, or creeping fat. In a normal person, the fat stops before it hits the bowel wall. In Crohn's, the mesenteric fat hypertrophies, and it literally grows over the surface of the bowel, wrapping itself around it.
Is this just a cosmetic finding?
No, not at all. It strongly suggests the mesentery is actually driving the disease. It produces inflammatory cytokines. It also makes surgery incredibly difficult because that fat is thick, it bleeds very easily, and it obscures the blood vessels.
We have to discuss cysts. Baily and Love makes a very specific and surgically important distinction between chylolymphatic and enterogenous cysts.
This is a classic exam question. A chylolymphatic cyst is a collection of lymph. It sits between the leaves of the mesentery. But critically, it has an independent blood supply.
Meaning what for the surgeon?
Meaning you can shell it out, you can enucleate it without damaging the blood supply to the bowel.
And an enterogenous cyst?
Well, that's a duplication of the gut itself. It shares a common wall and, crucially, a common blood supply with the adjacent piece of bowel. You cannot peel it off. If you try to remove the cyst, you will cut the blood supply to the bowel.
So the treatment is enucleation for chylolymphatic, but you have to do a segmental resection for enterogenous.
Correct. Knowing that difference before you start cutting saves the bowel.
Finally, in pathology. Adhesions. We talked about the good adhesions in embryology. These are the bad ones.
Scar tissue. The text classifies them. You have the angel hairs, these flimsy avascular strands. They can cause an obstruction, but they're very easy to divide. Then you have dense vascular adhesions.
And the text makes a really profound point here. Adhesion formation is basically the body trying to heal by repeating the embryological process.
The body thinks, I am injured, I must stick to the wall to stabilize myself. It's this primitive survival mechanism that ends up causing modern surgical headaches.
Let's finish with part 7. Tumors.
Primary tumors like mesothelioma exist. They're associated with asbestos, but they are very rare. The big player here is secondary carcinoma metastasis.
Peritoneal carcinomatosis.
This is when cancers, often from the ovaries, stomach, or colon, seed the peritoneum. They create these little nodules everywhere, and the greater omentum is a common target. It becomes infiltrated with tumor cells and turns into a solid, hard mass.
The omental cake.
It's a grim term, but it's very descriptive. You can sometimes feel it through the abdominal wall. It signals advanced disease.
Is there any good news here at all?
There is, sometimes. It's called HIPEC. Hyperthermic intraperitoneal chemotherapy. For certain cancers, like pseudomyxoma peritoneum, what they call jelly belly, we perform a massive surgery to remove all the visible tumor. That's cytoresection. Then we circulate heated chemotherapy fluid through the abdomen for about 90 minutes.
Why heated?
The heat increases the penetration of the drug into the tissues, and it also has a direct cytotoxic effect itself. It's the shake and bake procedure. It has transformed the prognosis for some very selected patients.
And lastly, desmoid tumors.
These are enigmatic. They are technically benign in the sense that they don't metastasize, but they are locally incredibly aggressive. They grow like tree roots into the mesentery and around the blood vessels.
That was a genetic link, right?
A very strong association with FAP, familial adenomatous polyposis, and Gardner's syndrome. If you see a desmoid, you have to check the colon for polyps. They have a very high recurrence rate after surgery, which makes them a nightmare to manage.
We have covered a tremendous amount of ground. I mean, from the origami of the embryo to the heated chemotherapy of modern oncology. Let's try to synthesize this. If we look back at this ready reckoner, what are the pillars?
Okay, first, the mesenteric model. Stop thinking of the gut as separate pieces. It is one continuous organ on a continuous mesentery. Stay on the island, the mesentery, for safety. Only cross to the seafloor, the retroperitoneum, when you really mean to.
Second pillar.
The switch. The midgut must rotate 270 degrees. Duodenum goes back, colon goes front. If it doesn't, you get malrotation, and that's a surgical emergency waiting to happen.
Third.
The pump. The abdomen is not a static bucket. It's a dynamic space where fluid moves up toward the diaphragm. So always, always check the subphrenic space for hidden infection.
And my big takeaway is the pain timeline. The shift from that vague, central, visceral pain to sharp, localized parietal pain is the body telling you the disease has breached its containment walls.
That is the essence of the acute abdomen right there.
So here's a final thought for you to chew on. Baily and Love explicitly states that the mesenteric model is the new standard. Yet, so many anatomy texts and medical schools still teach the old, fragmented model. Why does it take a generation for surgical reality to trickle down to preclinical education? And maybe more provocatively, if the mesentery is a continuous organ, is Crohn's disease actually a primary disease of the mesentery, with the gut mucosal ulcers just being a secondary effect? That creeping fat really suggests the mesentery might be the culprit, not the victim.
And that is the absolute frontier of research. If we treat the mesentery, maybe we cure the Crohn's.
We really encourage you to open Chapter 65, look at the diagrams of the rotation. They're worth 1,000 words.
And if you are still fuzzy on the difference between an interogenous cyst and a chylolymphatic cyst, please rewind to part 6. It might save you from a lawsuit one day.
Thanks for diving deep with us. We are your guides to the gut, signing off.
Stay curious.